I'm good, thank you.
Well, thanks. It's a real pleasure to be here today. Um, those those Rotary clubs that I've visited in the past, and I do try and do four to six of these a year if I can. The ones I visited in the past know that I always start by saying that they're some of my favorite talks to give. And so the reason for that is that it's a real privilege to be in the room with people who take it upon themselves to look at the world and aim to make it a better place. I work for the US government. Those of you who are US citizens are compelled to invest in the work that we do at CDC through your taxes. It's a little different when we talk to Rotarians. You go out of your way, you have your paycheck, you have bills to pay. These cases, we know what we're doing. And I do believe that this has been a hard year and there are hurdles in front of us, but also that this program, and those of you who have been involved in it for a long time know, that this program has a history of taking hurdles dead on, figuring out ways over them, and then continuing the journey. And I believe we're going to do that. Michelle, in his video address, can go down, but there's some challenges that came up, and I'll talk about those in a minute. Despite the challenges, there is some progress. It's worth pointing out that compared to about 8 years ago, we're down 80% cases, and we do remain in those tens of cases. There's a lot of community engagement in Afghanistan. When we can get in,
there is a willingness of the population writ large to receive vaccine and the services provided, and that's really important. And many of the religious leaders are in support of
vaccine preventable diseases at the same time. We think this engagement on the broader set of immunization activities is actually going to be critical to getting to that last case and beyond it in Afghanistan. Community awareness about that we considerable this year in Afghanistan. The big challenge is that the southern part of the country for all of for the last 3 quarters of 2018 and throughout the beginning of this year were inaccessible to the program. And so you had about 1 million kids that we couldn't get to for about a year. We had hoped that that would be resolved early in this year, but in fact, the Taliban pushed a little bit further and put a ban on WHO activities in the country. And WHO, as a major partner that administers, along with UNICEF and the other partners, these programs, that basically put a bit of a stall on reaching the children in the country. All is not lost, though. There's continued engagement and access in the areas we can get to. There's continued activity. And the program is really using this time where there's a bit of a pause in the vaccination to recalibrate and think about how to be best prepared to enter those areas and vaccinate the kids when we can get to them. The other thing that's happened is that we've set up these EOC structures that facilitate one program to deliver the services. And with some of the changes that have happened at various levels of the government, there's a reorientation towards continuing to have that set of, we call them emergency operations centers, EOCs, to have those EOCs remain that central strong point for administration of the whole program. And there is some considerable progress there. The last thing is related to the last bullet on the last slide, and that's really focusing on places that we know have been chronic refusals. We really worry about any kid that's parents have refused to allow them to have vaccine. We worry even more when, over a period of time, there are pockets of chronic refusals that can result in a gap in immunity that can allow the virus to spread. And so there's a lot of focus on those microenvironments and identifying ways to change access and change acceptability of vaccination in those microenvironments so that the children are vaccinated. I want to shift now to Pakistan. This is the map of Pakistan, and of course, Afghanistan and Pakistan are right next to each other on the map. And so when I talk about Afghanistan and Pakistan separately, I'm not really telling you the whole story, because the truth is that as long as we have virus in Pakistan, we're likely to have it in Afghanistan in reverse. There's a lot of population movement back and forth. The reservoirs of the virus are shared across the countries. And so when we accelerate efforts here, we're accelerating efforts in both countries. In any case, this is the picture of the cases for 2018 and 2019 for Pakistan. And what should jump out at you is the large number of increases in cases this year compared to last. Last year, Pakistan had 12 cases. This year, to date, we're at 47 cases. It's a big increase. It's an increase that is representative of not getting to zero in some core places where the virus spreads, and then spill over into places that have quite good vaccination, in fact, but some of these small pockets of chronic refusals that allow that virus to escape from population centers into these other geographies, increasing the number of cases. I want to be very honest with you. We're in the middle of the high season right now, because So you should expect that these cases are going to continue to go up. In fact, I've given you the numbers, but I know that next week we're anticipating probably 2 more confirmed cases already on the board that are likely to be confirmed next week. You shouldn't be dissuaded by this. As I said, it's a tough year. The Pakistan program is currently recalibrating its efforts and thinking about new ways to engage its communities to close those pockets that are gaps in immunity. Let me talk a little bit about the progress in Pakistan, and I'm going to come back to some of these issues of challenges that I've flagged already. The Pakistan program really does innovate, and so I've been very engaged with this program over the last 4 or 5 years, and I've been very impressed with the fact that the team itself is looking to see how it can improve the information coming in, the coverage and reach, the speed with which they respond to case detections or environmental detections, and new strategies like out of cycle, in between the rounds, having community vaccinators that go in and vaccinate populations. They also have a workforce that goes out in incredibly difficult situations. Some of these communities themselves are reluctantly involved in the program. They don't have other services. They don't necessarily have good, clean water. They don't have good, clean sanitation. They may not have health services, and yet polio shows up. We show up every month in Pakistan and Afghanistan, and the communities get frustrated that the government's not giving them more. And so these vaccinators go out into these tough environments on a every week and every month basis to deliver this vaccine. And there's a real commitment. And we don't see any wavering in that commitment from this workforce. And that's going to be incredibly important as we re-engage these communities in the coming months to gain access and to get to those last pockets of unimmunized children. The other thing that about Pakistan is that they've got one of the biggest environmental surveillance detection systems for polio in the world, actually the biggest. And so in addition to the typical way that we detect polio, which is through paralytic cases being reported, investigated, and then laboratory tested and confirmed for polio, we collect sewage samples from population centers and we test those for poliovirus. Actually, Mark tests them. And we can look at those viruses, not just that they're there, but we do genetic sequencing on every one of them so that we can determine where its closest known match is and where it may have come from, and learn about the transmission patterns through that. So in the country, overall, when you look at the amount of vaccine going out, polio vaccine going out, and the coverage it provides, it looks really good. Over 98% coverage by serosurveys and by the post-campaign monitoring and everything else in most communities. However, we know underneath that there's variability and places that coverage is quite lower. And that's the places where this virus is hiding. And so a lot of the focus as we recalibrate and try and bring these cases back down is to focus on those core areas, see what it is that is causing the lack of immunity. Is the community not engaged? Is the community outright against the program? Is the community there, but there are incoming migrants on a regular basis, people going in and out with a lot of rapid nature, and therefore we're missing kids? Or are there other details of those communities that actually impact how we engage them, such that we're systematically missing a small but very important group of children in the country? Right now we're focused on putting this community resistance at the front of the line for issues to resolve in the next few months. We're looking at everything that may impact that. The dialogue with the government, are there opportunities for us to help the communities engage better with the government to get some of these other needs that they require? Are there ways that we can find collaborating partners that will provide some of those other needs on a small scale to help these communities recognize that we're not there just for polio, but actually for their well-being, and thereby changing the communication back and forth with them. We're looking at the amount of vaccination rounds that we're providing. On the surface, you would think more is better, and so let's go there every week, let's go there every month. But in fact, the community gets quite tired. If you think about it, maybe you could think of like a book salesman coming to your door at your house and knocking on your door. In a given polio round, you might have 5 different people knocking on your door. The social mobilizers in advance, the vaccination team as they're delivering vaccine, the supervisor coming to check if the vaccination team was there, the monitors coming to see if the kids' fingers are marked or not, and then occasional surveys to determine how the services were. And so how would you feel if 6 times in a month you had a knock on your door that took you away from what you were doing with your kids or how you were cooking? And then imagine that happening every month with the same group of people coming through. And so we're really looking right now to say, okay, how can we provide this service and get to these kids, but do it in a way that is going to not be abrasive to these communities, because they seem to be a little bit resistant, and that's impacting the delivery of the vaccine to every child. We're also dealing with issues of cross-border movement. And so because of the back and forth, we've increased vaccination at border points. We look at rail systems and other transport systems, bus stops, and we put teams there to try and capture kids wherever they might be on the day that those rounds are happening, and to make sure that they have opportunities to be vaccinated. So as we think about the next steps, in Afghanistan, there's a lot of dialogue with the stakeholders to try and regain access in the south. There's also a lot of intensified partner engagement to improve the linkages between routine immunization and other health services in some key population centers. Specifically, the improvement of EPI is actually code technical jargon for the immunization programs of the countries. So expanding that engagement with the immunization programs in some of these key centers, but also generally, because polio is a vaccine preventable disease, and strengthening that routine immunization system will absolutely help accelerate polio interruption in Pakistan and Afghanistan. Along the northern part of the border between the 2 countries, we've seen a back and forth outbreak that's called the Northern Corridor, and so we're intensifying activities there to try and identify specifically when and how the migrations are happening, and making sure those kids have vaccine. And then continuing to intensify the National Emergency Operations Centers so that it continues to be one streamlined program in each country. That's really taken them quite far from where they were to being on the brink of being able to interrupt. But we can't seem to get that push, and that's the stagnation and the increase in Pakistan that we're seeing this year. And so using that model, we've decided that in Jordan, in Amman, Jordan, we're actually going to establish a hub that will deal specifically with Afghanistan and Pakistan directly. In US parlance, we would call this an emergency operations center as well. We call it a regional emergency operations center that will aim to streamline resource flows to these 2 countries, help them prioritize their work, have a surge workforce that can go in and help them deliver these services, and really bring the global program closer to these 2 countries as they become the very specific focus of the last bastions of wild polio virus that we have on the planet. I'm going to shift now to Nigeria. Nigeria is a bit of a different story. For those of you who have been around for a while, you may remember that from 2014, and I was part of the team in Nigeria back then. From 2014 to 2016, we didn't see any cases of wild polio virus in Nigeria, and in fact, we thought we had completed the job. Of course, if you watch much news, I watch a lot of news, or I did before I had small children. Now I watch a lot of cartoons. But if you watch the news, you'd know that something was going on in northeast Nigeria, though, and it was the Boko Haram insurgency had taken siege of Borno and was really operating heavily out of there. And we underestimated the number of people that were trapped in those communities. And maybe you remember the Chibok girls were front and center on US News for a while. These schoolgirls who had been kidnapped by the Boko Haram group. And eventually many of them, the good news is now that we know that eventually many of them were freed, but at the time it was unclear what their future was going to be. So Boko Haram had set up, and there were actually populations trapped. And so in 2016, as they lost some of their foothold in the state, out came some populations, and with them detections of wild poliovirus. A very intensified response happened after that. And in fact, we established partnerships within the national program, established partnerships within the country with the local groups that, civilian groups that engage on gaining access, and also with the national military that was very focused on gaining access. And through these extended programs, we were able to see a reduction in the number of trapped kids by quite a bit, and I'll talk a little bit about that now. At the height of Boko Haram, there were about 500,000 kids estimated to be trapped, and now the number that we use for those who have never had access to vaccinations is about 20,000. And so this number of gaining access to 100,000 kids, that's 100,000 kids that had never had vaccine before. But actually hundreds of thousands of kids were accessed over the ensuing years between 2016 and now. And this month will come up on 3 years without seeing a wild poliovirus case in Nigeria. Because of that, that 3-year mark makes the country and the region, because this is the last country in the region potentially eligible to be certified free of indigenous wild poliovirus. That is, the wild virus that's been there, that we've been fighting forever. Because of that, they're really focused right now on the data and analytics to understand the dynamics of where we have surveillance, where we've gained access and given vaccine, and whether or not there are trapped populations that remain, and how big they are, and whether they are considerable enough that we don't have the evidence that we've completed the job, or whether they're there and important, but even with them notwithstanding, we still believe that the virus is absent. So there's a lot of work going on right now on that issue. But that's not the whole story. And actually, I was in Nigeria this week, and I'll tell you a little story about that in a second. That's not the whole story. So in Nigeria, they did an incredible job to push for the interruption of wild virus. There are pockets of the country that have lower immunity and some that have higher. And so because of that, they've been experiencing some vaccine-derived poliovirus. And that vaccine-derived poliovirus has been circulating now. And so when you have low immunity in the community, on very, very rare instances, the vaccine can mutate, and then that mutated vaccine virus can cause paralysis and can start circulating. The way out of it is to vaccinate more. This is a very confusing and complicated issue for people, right? Because we're preventing virus with the vaccine, and yet here John has just said that on rare occasions the vaccine can cause virus. I want to give you a little bit of scale for that. Since the reversion happens in less than 1 in a million doses of vaccination, and since the start of this program, largely oral polio vaccine has been responsible for preventing 18 million cases of paralytic polio. And we've ever recorded only 1,100 cases of circulating vaccine-derived polio. Of course, every one of those cases is critical, because every one of those cases is a child that is getting paralyzed. And so we're working very closely with the Nigerian program right now to intensely vaccinate the population to stop this circulating vaccine-derived poliovirus, in addition to working with them to determine whether or not there's the evidence that they have in fact interrupted wild poliovirus vaccination. We continue, even though there's been a lot of progress in Borno, we continue to push to get the last remaining kids that are still isolated in Borno, to get them vaccinated, and to make sure that we're determining whether or not there's any virus there through cases detected or environmental sites. And we continue to work with them because they are in transition to continue to strengthen their routine immunization program so that the background immunization rates come up and we don't have to worry about continued potential transmission of any type of poliovirus. So what are the next steps there? They're going to expand their immunization, as I just said. There's going to be the country has prioritized a greater investment in primary health care. And they're investing in disease surveillance and response. And this is really important because once they come off this list, we want to make sure that if anything should come up, if there's any importation from somewhere else, if there's any event that needs to be aware of, if a vaccine-derived virus does happen, that they detect it very quickly so they can respond very quickly and then stop it in its tracks. I mentioned that I was in Nigeria this week, and it again, Carol knows because she was at CDC yesterday, Carol Pandak from the Rotary Plus committee. I was wowed by a Rotarian in the field. I was in Ilorin in Kwara State, in rural Nigeria. We were doing a polio round, and we were out reviewing the situation, and there were 2 kids by 2 separate mothers that were, the mothers were not convinced that they should give the kids polio vaccine. And this young, probably in her early 20s, maybe late 20s, Rotarian came in and said, we need to go see the village chief. And so we went to the chief's house, and usually these are very ceremonious visits, and they take quite a while. Within 3 minutes, that young Rotarian went to the chief and said, sir, we have a problem. There are unvaccinated kids in your village. We need to do something about this. The chief turned around and said, let's go right now. Got in his car, drove over there, and within 20 minutes, both those kids were vaccinated. And we were on our way to the next village. The commitment of one volunteer who, like all of you, is doing this for the good of other people. So I talked to you a little bit in the context of Nigeria about circulating vaccine-derived polioviruses. You can see from this map, the red dots are wild poliovirus, so don't focus so much on that. Focus on the green dots. And these are circulating vaccine-derived polioviruses that we've seen in the last 6 months. Nigeria is not the only place that this is happening. We're seeing them in several places in Africa. We're seeing them in other places beyond Africa, in pockets of immunity that are low, in countries that don't have strong routine immunization systems, and therefore we have a lot of them going on at the moment. I'll talk about a couple of them, but not all of them, just because there are many. The key messages are the same for all of them. We've got to get to the kids and vaccinate them. So in Democratic Republic of Congo, they have several outbreaks going on, again, in these small places, and we're actively engaged. They actually have 8 separate outbreaks of circulating vaccine-derived poliovirus that we're responding to and have been for about 2 years now. With some progress in those early responses, but more creeping up, and again in those places that in the terms of the response they didn't have high coverage of vaccine. In the Horn of Africa, we're also responding in Somalia and Ethiopia, and there was a detection in Kenya, but we haven't seen it in Kenya for quite a while, but nonetheless ongoing active outbreak response in Somalia and Kenya based on detections there. And in Lake Chad, so in the areas around Nigeria, we're also in northeast Nigeria has Lake Chad. The Lake Chad countries are several and include Chad, Niger, Cameroon, Nigeria, and CAR. And so several of those countries we've now had spillover detections of these circulating vaccine-derived viruses and are responding actively through vaccination in those places. I wanted to talk a little bit about some of the things that we do. How do we manage this, right? And so this is a very complicated set of maps, and you don't need to know all of the data on these maps. But we have been very active in using satellite imagery to actually look and see where people are residing in these areas, because they don't have necessarily strong road systems, strong mapping systems, strong records. And so we use satellites and we look at these areas and say, okay, where do we see evidence of human habitation, how based on the size and shape of that, we can determine what the estimated population is. Whether they have roads that have vegetation or not, we can determine whether or not there's been back and forth and movement between those places recently. And then we can go in and set vaccination teams up to deliver vaccine. We also, in several countries in this area, can give the vaccinators phones, really, but they're GPS trackers, and so we can determine how far they've gotten, where they've delivered vaccine, and where that remains. And so we're applying a very active technology to one of the most remote regions on the planet to make sure that we're gaining reach and improving access to this vaccine to stop these outbreaks. This is just a quick list of the countries. As I said, there are many that are engaged in this. My team, actually I got a map yesterday and I looked at it, and when they put it up on the screen I said, wow, and the guy who had created it, it's our deployment map. It tells us where all our staff are in the world, and I get these twice a week. And he's like, yeah, I'm not surprised you said, wow, you've got more people in or going to the field than you've ever had in the last 5 years. And so that's because they're going out to respond to these outbreaks. Okay, so that was pretty heavy. Let me end on a little bit of a lighter note. We're zeroing in on this, and we truly are, and I believe it. Type 2 was declared eradicated in September 15, and some of these outbreaks that we're seeing now are because we stopped using in the routine system the type 2 oral vaccine. It's always been part of the plan that because the vaccine is live, when we finished a particular virus, we would want to get rid of that vaccine. And so this is a bit of, these outbreaks now are a bit of a cleanup because in 2016 we stopped using that vaccine globally except for outbreak response. Type 3, the last case was in November of 2012. And this year, in the next few months, the Global Certification Committee will be making a determination as to whether or not they believe type 3 wild indigenous virus is eradicated. The evidence looks quite good for it. We will see, there's an estimation that perhaps around World Polio Day there might be some determination made. So please look for that. That could be a real good news story for the year. In type 1, as I've told you, we've seen some hurdles this year and the cases have gone up compared to last year. I want to assure you that we will overcome these hurdles. We will recalibrate, we will address these, and I'm wholly confident that we will eradicate polio. If this was going to be easy, it wouldn't be worth doing. You all know that. You've been doing it for almost 30 years. We're down to two countries with real big problems, yes, but countries that we can work with to solve the problems and get the vaccine to those kids. I'll end with just, I like to talk about my kids a lot. Some of the folks at that table know this. I'll end with a quick story about my daughter and I. My oldest daughter is 4. And I was headed off to Nigeria last Saturday night and came back on Thursday. And so I was talking with her about why I was going to Nigeria. I travel a lot, so it's not unfamiliar territory for her, but she's old enough now that we can actually talk about things that really matter, besides food and treats. And I said to her, you know, I'm going out, you know how you got your vaccines, and we talked about that. Well, I'm going out because I want to help these kids who don't really get vaccines in the way you do in the doctor's office. And so we have to go, and we have to go to their houses, and we have to give it to them, and that's why I'm going. And she said, oh, okay, and you know, how long are you going to be gone, blah, 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 blah. But then, well, where are these kids? And I said, well, they're in small villages in Nigeria, and that's where I'm going to be going. And she said, okay. And I said, well, do you know how many kids we're trying to vaccinate? And she said, oh, I don't know, 20,000. And I said, that's a good guess. I said, but actually, would you be surprised, Aaliyah, to know that it's every single kid in the whole world? And it registered with her. And the reason it registered, we have 2 rules at home. We don't like to have lots of rules for the kids because it's hard for them. But the 2 rules are, first one is we don't lie. The second rule is, and it applies to all of us, these rules. The second rule is that we do what we say we're going to do. So if Daddy said we're going out to vaccinate every kid in the world, that's what we aim to do. And that's what you're all expecting of us when you make your contributions and you put this as a priority. And I'm committed to seeing that happen. Thank you very much. Always